You're welcome to my channel. Today I'll be addressing fluoroquinolones. This is a class of antibiotics with a broad spectrum bactericidal activity against gram-negative, anaerobes, and some gram-positive agents. It's pretty useful in both human and veterinary medicine. Fluoroquinolones contain a fluorine atom with a bicyclic core structure related substance known as fluoroquinolone. Examples here are Ciprofloxacin, Delafloxacin, Gemifloxacin given per oral only, Norfloxacin given per oral only, Levofloxacin, Moxifloxacin, Ofloxacin. The list also includes Pefloxacin, Trovafloxacin, Grepafloxacin, Gatifloxacin, Sparfloxacin, and Prulifloxacin. When it comes to coverage, we are dealing with broad spectrum antibiotics, right? So we should expect any member of this very family, that is any of the fluoroquinolones, to have broad spectrum activity. And the activity, the level of coverage will include aerobic agents, respiratory pathogens, enteric gram-negative agents, Pseudomonas aeruginosa, some gram-positive agents, even anaerobes, mycobacteria. Ciprofloxacin, for example, is pretty useful in handling aerobic agents, Pseudomonas aeruginosa, gram-negative bacilli, respiratory Haemophilus influenzae, Moraxella catarrhalis, and the list goes on. Levofloxacin is useful to handle Mycoplasma, Legionella, gram-positive agents, respiratory agents, Streptococcus pneumoniae, and so on. Now, Moxifloxacin. This will be helpful in handling anaerobes, Mycoplasma, Legionella, gram-positive agents, respiratory infections, including lung abscess. Remember, can handle anaerobes, Streptococcus pneumoniae, and so on. Delafloxacin is the newer generation of fluoroquinolones, pretty useful to handle anaerobes. And a great advantage of Delafloxacin here would be that it can handle methicillin-resistant Staphylococcus aureus. Generally, we don't use fluoroquinolones for gram-positive agents, but some of them can handle gram-positive agents. So in some cases, we may. The following fluoroquinolones will have no activity, meaning zero activity against gram-positive agents. And here we have Ciprofloxacin. So ciprofloxacin is not good when you have microscopy, culture, and sensitivity, or empirically, you are thinking this is going to be caused by a gram-positive agent. Don't choose ciprofloxacin. If you do, you are not going to get any good outcome. Also, Norfloxacin will have no activity against gram-positive agents. The same goes for Ofloxacin and Prulifloxacin. So we should know this. All this will have no activity, meaning they have zero against gram-positive agents. When you are dealing with tuberculosis and your rifampicin or rifampin, ethambutol, pyrazinamide, isoniazid, in addition to pyridoxine, to relieve the side effects of peripheral neuropathy of INH, and you want to have fluoroquinolones to handle your tuberculosis, then you can choose Moxifloxacin or Levofloxacin. Mycobacterium leprae, you can use dapsone, right? But you can also use Moxifloxacin or Floxacin. And of course, you can use chlorphazimine. In anthrax, you can use all fluoroquinolones. In typhoid fever, you can use all fluoroquinolones, but ciprofloxacin is more important when it comes to typhoid. Mechanism of action. Bactericidal activity is done by inhibiting bacterial DNA synthesis. They all bind to DNA gyrase and DNA topoisomerase 4, which will lead to DNA cleavage. The cleavage will lead to death of the bacteria. Pharmacokinetics. When you give fluoroquinolones per oral, bioavailability is pretty high. For example, you can give Norfloxacin per oral only. Levofloxacin, if you give it per oral, bioavailability will be as high as greater than 90%. Ofloxacin will give the same. Moxifloxacin is about 80%, while Ciprofloxacin is less compared to those above with 70%. Delafloxacin will be pretty low but still good to be given per oral with greater than 60% bioavailability. Absorption from the upper gastrointestinal tract can be impaired when you concomitantly administer fluoroquinolones with any of the following agents: with milk, antacids, zinc, sucralfate, magnesium, aluminium, calcium. All these will form cation quinolone complex. Therefore, it is expedient to give them at least 2 hours apart. Or it could be up to 3 hours, so 2 to 3 hours apart. It can accumulate in stools, in the prostate, in bile, the lungs, neutrophils, kidneys, and urine. All will be eliminated by renal system except Moxifloxacin. That informs the reason why it's not used in urinary tract infection. Some tag fluoroquinolones as big brother antibiotics. Why that? We just don't go for fluoroquinolones when we're handling minor cases. For example, cystitis without any complication of any sort, or acute bronchitis in patients who just want any antibiotics. No, you can't grab fluoroquinolones to play around like that. But in the face of severe infections, yes, go for fluoroquinolones. However, we must consider the side effects also. Another question is this patient pregnant? If the answer is yes, then no fluoroquinolones. You ask, is this woman breastfeeding? If the answer is yes, then no fluoroquinolones. This is a child less than 10 years, right? If the answer is yes, please don't give fluoroquinolone. Why that? Just wait, I'll tell you. You may use fluoroquinolones in children 8 years and above if there are no other effective antibiotics available, and you must use no antibiotics, right? Well, you can use it, but it must be for the shortest period of time possible to handle the agent, and it is only after you must have explained the side effects to the parents and you've gained consent. Drug-drug interaction. Ciprofloxacin, for example, is an inhibitor of hepatic cytochrome P450 enzyme, thereby increasing the availability and toxicity of many other drugs. And these will include caffeine, clozapine, tizanidine, warfarin, ibrutinib, theophylline, and norfloxacin can increase the effects of theophylline even specifically, and also ropinirole. Still on drug-drug interaction, hepatic enzyme inducers, for example, rifampicin, or carbamazepine, or phenobarbital, or sodium valproate, and so on, can reduce the level of moxifloxacin, and why that? They're going to shoot hepatic enzymes out, breaking down fluoroquinolones. There are many other drug-drug interactions. I can't go through the list of pretty long medications and what exactly will happen. So my advice is contact your pharmacist or your clinical pharmacologist to find out before combining those medications. Now, adverse reactions. Good antibiotics, yeah, but that is not without serious and less serious side effects that the patient must be told, or on account of which we may decide to choose other antibiotic or antibiotics entirely. Let me explain. This is a good medication, right? But there are so many side effects. Some are serious, some are less serious, but the patients that will be taking these antibiotics deserve to know both the less serious and the very serious side effects, because the option is right there to choose another agent entirely. But as a good news here, when it comes to fluoroquinolones, Delafloxacin is a new generation. Delafloxacin is expected to have less side effects. The reason why I use the word expected is that there is idiosyncrasy, whereas somebody will react just in a particular way that is peculiar, not found in the general population. So the fact that you are listening to this and I might have said, oh, the Levofloxacin should have less side effects, and you are given, and then you have no serious side effects, and you say, oh, the guy didn't tell me the truth. So it is expected. But because of idiosyncrasy, it might be in some few patients that they will have serious side effects as well, even with the use of Delafloxacin. But little is known about Delafloxacin for now. And why that? It is a new drug. We will know more about the side effects in years to come. Okay, the first side effects to be considered by me would be musculoskeletal problems. Here, it could be tendinopathy or arthropathy. Okay, tendinopathy, like Achilles tendon, could be ruptured, but can be any tendon. Okay, so we have to stop the medications if there's joint pain and swelling, and we tell the patient not to be involved in severe exertion. Arthropathy with cartilage erosions, for example, in children, on ciprofloxacin is going to be a big issue. However, they do have reversible experience with norfloxacin, meaning if this is norfloxacin, arthropathy is reversible, okay? But with ciprofloxacin, it's going to be a serious issue. And that is one of the major reasons we don't give it to children. So, anyone less than 10 years, no ciprofloxacin, no quinolones. Another adverse reaction is gastritis. Here, there will be less diarrhea, but it is associated with nausea and vomiting and anorexia, and some will actually develop abdominal discomfort. Clostridioides or Clostridium difficile infection is going to occur because it has a broad coverage, and here the affected person will have pseudomembranous colitis. Prolonged QT syndrome. With the use of fluoroquinolones, the QT will be prolonged, okay? And with prolonged QT, there will be torsade de pointes. If there's no correction, torsade de pointes will degenerate to ventricular tachycardia. Initially, it will be monomorphic, but will progress to polymorphic ventricular tachycardia. If no correction, that will degenerate to ventricular fibrillation. Without defibrillator, there will be asystole. Without advanced cardiac life support, intervention instituted quickly, then the patient might die. The patient will end up in the morgue. So we don't use this medication with other medications that has the capability to give us prolonged QT. For example, chlorpromazine, olanzapine, erythromycin, and so on. Then hepatotoxicity. That's a big problem on delivery, right? But Moxifloxacin and Levofloxacin will lead to hepatotoxicity. Ciprofloxacin, on the other hand, has less, hepatotoxicity, but it is worth mentioning that it can also give us that. There is a good news here. Trovafloxacin was known to have fatal hepatotoxicity. And the good news there is because someone is saying, what's good about that? It has been withdrawn from the market. It has been withdrawn from the market, meaning if the current fluoroquinolones that are available will give fatal hepatotoxicity, then you won't find them on the market. Or when the data is showing that, of course, they pull them off because they don't want people to die. Still on adverse reactions, central nervous system. With the central nervous system, there might be a headache, altered sleep pattern, dizziness, changes in the mood, delirium, hallucinations, agitation, and cognitive impairment. So we need to explain this to anyone taking fluoroquinolones that don't drive, don't operate forklift, don't fly plane. You may be confused. You might have, hallucinations as well. Neuropathy here will be peripheral neuropathy. And that will start from any time the patient is on that medication, and it can last till any time. And it might be permanent neuropathy in some people. So they need to know about that as well. Seizures as adverse reaction is not pretty common, it's very rare, but it is more pronounced when fluoroquinolones is used concomitantly with non-steroidal anti-inflammatory drugs, or when it is used with theophylline. And with that, it will augment the capability to displace GABA from its receptors, okay? And anyone on fluoroquinolone could have pseudotumor cerebri. Neuromuscular junction blockage. It has a tendency to do that, okay? So not helpful in anyone diagnosed with myasthenia gravis. Don't use fluoroquinolones in a patient known to have myasthenia gravis. In aortic aneurysm or aortic dissection, the risk will actually increase. So if the risk of aortic aneurysm or aortic dissection will be high because the patient is on fluoroquinolones, then you don't give it. We don't give it in anyone who is known to have aortic aneurysm or when that is suspected. In mitral valve prolapse, we have to avoid the use of fluoroquinolones, particularly mitral valve prolapse and regurgitation. So, no fluoroquinolones, please. Glucose metabolism. Fluoroquinolones may give hypoglycemia or hyperglycemia. Here, Moxifloxacin specifically will have the worst trouble with glucose metabolism. So, if I'm dealing with a patient with diabetes mellitus and I have to choose any antibiotics, I'll be careful when it comes to fluoroquinolones. But if it is giving my patient, hypoglycemia, meaning the glucose level is dropping, and this is a patient with diabetes mellitus always having high glucose level, that's a good news, meaning I will have to reduce the dosage of my hypoglycemic agents, okay? So metformin level will have to be reduced. The quantity of insulin will have to be reduced. But in people who are just getting the glucose level, going up and up, I will not use fluoroquinolones. In retinal detachment, it is not so much a problem, but it can happen, and that is why it's worth mentioning. Phototoxicity. This is less pronounced, particularly in the new fluoroquinolones like Delafloxacin. Okay? Hypersensitivity reactions. It might be immediate, that will present with anaphylaxis, but that is not common. It will occur suddenly, while delay onset with maculopapular rashes can also occur, but not as common also. Fluoroquinolones-associated disability or persistent multisystem adverse effects can be the situation with any of the fluoroquinolones. And among the patients using the topmost 3 fluoroquinolones, and someone is asking, you didn't give us the list of topmost 3 fluoroquinolones. Okay, I'll give you right now. That is Moxifloxacin, Levofloxacin, and Ciprofloxacin. Now, resistance to fluoroquinolones. This is growing now worldwide, okay? Less resistance is occurring with H. influenzae, and Quaternalis, and Strep pneumo. Specific uses. I'll just go through a brief list. It's more than this. So, in sexually transmitted infections, now in urinary tract infection, Pseudomonas aeruginosa, in typhoid, paratyphoid, cholera, traveler's diarrhea, shigellosis, Campylobacter infection, respiratory tract infections, infective endocarditis, chronic obstructive pulmonary disease, particularly acute exacerbation, bite or surgical wound, and the list goes on. With that, I've come to the end of this presentation as per fluoroquinolones broadly. The most important thing here is knowing when to use a particular fluoroquinolone and let the patient know the side effects that he or she might be dealing with very soon. With that, come to the end of this presentation. Remember to share this. Remember to subscribe to my channel. I appreciate it.